Well, good morning, ALK community. It's a pleasure to be back with you this morning with three very august individuals here. I don't know, Carl, I think this is your first time joining us in an ALK Summit.
Yeah,
Welcome.
yeah, definitely. It's been a real treat to be here. So it's been
Thank you.
fantastic.
And Vincent's up here for 10th time or something like this during.
It's not a rerun.
We're always glad to have you. And David, this may be your first ALK
Yeah,
Summit.
it is my first time.
And he's a hometown boy here, so we've seen a lot of him, and it's really been awesome. So, David, can you tell the group just in a moment, Sarah Cannon Research Institute, what is it and what role does it play? How many oncologists are involved?
Well, so we're just, I was telling Vincent, we're like 3 blocks away, which is where we're headquartered. So we're an organization that runs clinical trials. And so I was mentioning yesterday, for example, we dosed kind of the first person in the world with lorlatinib and are working on the Nuvalent program now. So we run clinical trials, phase 1 through late phase, but not only in Nashville, around the country. So we have a network that includes 31 states, 2 academic centers, and actually in London. And so we've been around for about 30 years. Vincent said, well, wait a minute, you're across the street from Vanderbilt? And so that was actually our origin story. My mentors left Vanderbilt and formed Sarah Cannon in 1993. I've been there about 21 years. I'm the chief scientific officer. And so our mission is to bring innovative therapies to patients in the communities where they live. We love our academic partners, couldn't exist without them. But we realize that most people who want access to new and innovative therapies can't travel to the big cities, to Boston, to New York, to Houston easily and kind of stay there to get their care. And so our whole mission is to have trials be available in the communities where you live.
Thank you, David. And I'm making the assumption everybody knows Johns Hopkins and MD Anderson here, but thank you for that. So when we had our panel yesterday, we focused on first-line trials and spent a lot of time on lorlatinib. Today we're going to switch it over and we're going to talk about progression. And what do you do at progression? It's not a simple question, right? So we're going to take 2 case studies this morning. The first is going to be, what do you do when it looks like your tumor is driven by mutations in the ALK gene, roughly 50% of the time, depending on which TK you're on, and we'll get into that. And then second, what do you do if there aren't any mutations in ALK gene? How do you know what's driving it? We heard Ross talk yesterday about MET being a common driver. And you can go online and you can pull a review article out and you'll find there are a whole lot of different potential genetic drivers in ALK positive lung cancer at progression. So we really want to try to think and hopefully leave time for questions to think about the reality of the situation is that we all the patients need to be prepared with the uncertainty that we were talking about yesterday. So let's get started then. We're talking about a 43-year-old who presented with right-sided chest pain and cough for about a month. The patient was fortunate enough to get a chest x-ray which showed a lung mass with a hilar and mediastinal lymphadenopathy and a lesion in the liver. When the biopsy came back, it showed it was adenocarcinoma of the lung. It was negative for any brain metastases, and there was an ALK rearrangement. So that patient was fortunate enough then to get started on one of these great ALK TKIs we have and had a complete clinical response. Something to be celebrated, right? Several years later, 2 new lesions were identified, one in the lung and one in the brain. The imaging was found at just their routine scan, their every 3-month scan. No clinical symptoms, biopsy confirmed it's still lung adenocarcinoma. The genomic testing again showed the rearrangement, but now some new mutations in the ALK gene. So the question for the panel is, what do you do? Do you do more biomarkers? How do you decide on the treatment? Here we have lesions in the brain and the lung, so it's not so simple. So we'll just start. I don't know who would like to take a first crack at it. David.
Yeah, sure. Well, a couple of quick things just in the presentation, just to make sure everybody kind of recognizes, and as you become good ambassadors to folks who get just diagnosed, it's important to know. So MRIs really are the best way to kind of evaluate somebody in the beginning, but with dye. I know that gets, sometimes that's the doctors that make those decisions and how they order it, but too often I see either head CTs or MRIs without dye. You have to get dye unless there's a contraindication to that. But I think the workup was the correct workup, and we don't know what ALK inhibitor this patient in this example got, but that would be in my kind of algorithm, like what are you on, how have you done with that drug? So for example, if you were on alectinib and have done really, really well, let's look at now what's changed. And so is that really a new lung lesion? Is that really new brain lesion? I know without asking these guys, they've had a million scenarios where a radiologist says new lesion, and then we go back and look and it's not a new lesion. And so I'm very critical of what are we saying is new? What's changed? Is there something clinically that's changed? Is there something objectively that we can see? And if we're convinced there really is new disease, then the question is, what should we change in your care? I try to get biopsies if we can. It's not always feasible. And you know, the scenario in the clinic that day is always challenging because you're discussing a change in care, which is stressful for everybody. And you want to make a plan of care. And so to do a biopsy might take a week. To get results back might take 2 or 3 weeks. And so are you going to sit and wait and not do anything for 2 or 3 weeks? I draw blood because that comes back in 7 days, but I'll be honest, rarely does blood change my care from that day in the clinic. Usually what we talk about is switching to another ALK tyrosine kinase inhibitor if we can't solve the changes locally. So maybe radiation therapy to 1 or 2 spots would be sufficient, but if we're going to change systemic therapy, I usually change to the next ALK inhibitor that the patient has not received.
Yeah, I totally agree with David's approach. I mean, I would highlight one aspect that I don't think is not quite clear in terms of the presentation. You know, how extensive the new lesions are. I mean, or where they're located. For instance, in the lung. Is this an area that is amenable to local therapy, as in radiation? The general paradigm here is that assuming you're tolerating the current ALK TKI well, we generally try to keep patients on that ALK TKI if there is limited sites of progression. The thought here is that the drug is generally working quite well, except there may be just 1 or 2 spots that need a little bit of a touch-up. And we have seen, and Ross's group did a lot of this early work, you know, we have seen that you can prolong patients' time on the TKI by local therapy to these hot spots. So that's one thing that I would be thinking about. You know, there it says progression in the lung. Well, what does that look like? Is that a lymph node? Is that an area in the lung that could be easily treated with a focused radiation? The brain actually is an interesting sort of site of progression because yes, you could also do focused radiation to the brain, although there's a couple other considerations there. One, I think as we mentioned yesterday, one thing we're seeing is in an era where we have highly active drugs in the brain, when we radiate lesions in the brain, we appear to have a higher incidence of this sort of inflammation, pseudo-progression, as you may have heard, or when it progresses, this sort of inflammation progresses, it may turn out to be something called radiation necrosis, which can actually cause the similar or the same symptoms as a brain metastasis. So, these are can be quite serious. So one of the things that I think we, as a field, may be moving away from is, stereotactic radiation to asymptomatic brain lesions if there's an option to basically step up the ALK TKI to a more brain penetrant drug. So that's one consideration in terms of this brain metastasis. That's the thing that I think in my mind really sort of is a bit of a twist in terms of an algorithm moving forward for this patient. If you didn't have the brain metastasis, I would say maybe we should explore radiation to that one lung lesion and then continue the patient on the TKI.
Yeah, and I'll just build on that. I think there's some nuance to this case that depends on which TKI they've been on before, which has been alluded to here, right? I think if this patient is on, say, alectinib or brigatinib, and indeed new ALK mutations have been identified, then you know what your next line of therapy is probably going to be in that scenario, and you know that it gets, lorlatinib gets very good CNS penetration, and that you might be able to control that brain metastasis with a switch. That said, I think if you were on lorlatinib at this point and your next line of therapy might be a clinical trial drug, then perhaps you would continue lorlatinib, as Vincent mentioned, and radiate one or both of these spots and kind of delay the switch of therapy. These mutations are presumably clonal events. Now, this has happened in two spots where we're not going to biopsy the brain, but we're assuming the same resistance mutation that's happened in the lung has probably happened in the brain here. And so I think if you remain on the same tyrosine kinase inhibitor, say lorlatinib in this case, I do think probably short interval follow-up is in line, because there's probably some microscopic disease somewhere in between the lung and the brain that carries the same resistance mutation that may pop up somewhere down the line. So you might shift from every 3-month imaging to every 2-month imaging or something at that point. But in general, I agree with the scenarios just as you all laid them out here.
So, Carl, you and I met the first time because you wrote me an email and said, we'd like to talk about a proposal from MD Anderson. And it doesn't fit exactly in the progression scenario, but it has to do with the role of surgery in stage 4 lung cancer. And I wanted to know if you just, let's assume this was just a recurrence outside the brain. Could you say something about how you're trying to include surgery in?
Yeah, so I think, and I mentioned this yesterday in one of the panels, I think our thoracic surgery team at MD Anderson has been especially aggressive in offering surgical options to patients that have stage 4 disease, but have driver mutations like ALK fusions that have extremely fitting targeted therapies. I think their preference is to offer surgical resection early to patients. So for example, a patient that had initially multiple sites of disease, but many of those sites have responded completely, and they may have residual disease only in the lung or only in the lung and lymph nodes. Our surgeons are very, very aggressive about resecting those in the hopes that some of those clonal mutations that might be hiding in wait there are removed completely from the discussion. In a situation like this, where the patient has progression of disease focally, I think it's more of a toss-up between radiation and surgery, but certainly there is an openness to surgery, even in the brain. If there's focal progression in the brain and it's symptomatic, I think you can often get some of your multidisciplinary colleagues to understand this situation, that if you can render this patient back to their no gross evidence of disease status, that you may be buying them years of survival with that. And I think that's something that surgeons and radiation oncologists are coming around on as these drugs get better and better. And I think it's something that it's our task, though, to convince them. In addition, I think the patients make a very compelling case when we send them to the clinic and force them to address the patients face-to-face and tell them they can or cannot undergo surgery. But I think we really have to emphasize to them that we've come a long way from crizotinib in this case, and these patients have many, many years, decades of survival ahead of them.
Thank you, Carl. So if you end up with this scenario and it appears that it's new ALK mutations drive, do you do any additional studies on the biopsy material to make sure there isn't another driver that might be complicating this and that the mutation isn't really the issue?
You want to take it?
Sure. So actually, just going back to Carl's statement about surgery, I think it's really exactly the right thing to do, just to consider all options. Highlighting actually what you had mentioned earlier, Carl, about this scenario, depending highly on what type of TKI the patient was already on. So for instance, I don't think this happens anymore. I would hope it doesn't happen anymore in 2024. If the patient was put on crizotinib and then progressed in the brain like this, I would absolutely not do surgery, because we know that crizotinib doesn't work in the brain. And so if you actually switch to something that actually worked in the brain, that would be much better. That would take care of a more sort of global problem. And maybe the same analogy or consideration could be made if the patient was on alectinib or something, and there was an opportunity to go on Nuvalent, for instance, as a clinical trial, which we know is specifically designed to have, exquisite brain activity. So all options should be on the table. It really is what highlights the need for sort of a multidisciplinary consideration for our patients. In terms of biomarkers, I absolutely agree when feasible. Upon progression, you should always rebiopsy if possible. And to David's point, this is really a tough conversation sometimes because, both ourselves and the patients really just want to get a new plan going that day. And so a lot of the discussion is about sort of explaining and reassuring that it really is worthwhile to incur maybe a 2-week or even a 3-week delay to get this information to make sure that we actually are crafting a plan that represents the best shot on goal, so to speak, for this next move. But all the time, we always send liquid biopsy in this situation, and then we also try to get a tissue biopsy as well. And why do we get a tissue biopsy? Because the liquid biopsy, number one, is not 100% sensitive. It can miss some of these mutations, which would then inform whether or not, for instance, lorlatinib may be especially helpful. You heard yesterday that while lorlatinib works generally about 40% of the time in patients who progress after a second-generation TKI like alectinib or brigatinib. It works much better in patients who actually have an acquired resistance mutation for which lorlatinib is sensitive to. So it really is worthwhile to try to identify whether or not there's these resistance mutations. And so liquid biopsy is a great tool for that, but it's not super sensitive, and it doesn't capture other potential acquired resistance drivers that are not within this ALK kinase domain that Christine talked about yesterday. For example, MET being the most common of these. So the liquid biopsies are a little bit challenging in picking up some of these MET resistance mechanisms.
Yeah, the only thing I'd add is we're learning all the time. Things are evolving, and we're learning a lot from other disciplines or other cancer settings. For example, in breast cancer, lung cancer research was so far ahead of breast cancer research, but now they're catching up in a good way and teaching us a lot of things. And so I want to hit on just something Vincent was mentioning. There's some complexities in just getting a new biopsy and thinking that report that comes back to you is going to give you your plan. Number one is there's tumor heterogeneity. So where your needle goes, you hope that's giving you a picture of everything that's happening in the cancer, but we know cancer doesn't work that way and follow the rules. So it may be, this diversity that Ross was kind of commenting on yesterday, that may not really explain what's happening in all the tumor lesions around the body or the ones that are spreading. And if you can't get to them, for example, in the brain, do we really know what the DNA makeup is of that tumor? The other thing is, as Vincent alludes to, there are other resistance mechanisms, and I mentioned this yesterday, I think, that are called fusions. So other than ALK, for example, there's RET fusions. You can have fusions in BRAF, for example. Some of our colleagues at Sloan Kettering are looking at what do you do if you have a BRAF alteration in the setting of an ALK alteration? Should you be on a BRAF inhibitor and an ALK inhibitor? We don't know that yet. In fact, Helena Yu is doing a trial to look at that very question. But you're not going to pick up fusions with blood easily, and you're not going to pick up fusions if you don't also look at RNA. And a lot of the tissue DNA testing is only DNA testing. Foundation Medicine, Tempus in Chicago, Foundation in Boston, Caris are now kind of expanding their offerings and their panels to capture those new fusions. The other emerging thing, and it's foreign to us, but it's becoming more clear, is we're going back to immunohistochemistry. So that's just staining for proteins. And so why is that even relevant? Well, you can pick up ALK, as you may know, with immunohistochemistry expression. Sloan Kettering does a lot of that as a quick screening. Most centers around the world do not do IHC expression testing. But we're learning about things like HER2. You know that in breast cancer. So HER2 is a rare alteration in lung cancer, but alterations in the HER pathway may be a mechanism of some resistance and open up options in other therapies. And we're learning in the breast cancer research field as recently as this last month that you may just need little expression of HER2 to know that a targeted agent like an ADC, antibody-drug conjugate, could be effective. We know that's true in breast cancer. Is it true in lung cancer? We don't know. But right now, our testing, maybe yours at your center, are you guys doing IHC routinely?
Oh, yeah, we recently just started doing IHC for HER2 recently.
Yeah, this is brand new. And so you're going to see the vendors, and some of them are here, but Foundation, Tempus, Caris, I'm sure, are going to start routinely adding HER2 IHC. And what about MET? Are you doing MET IHC?
Not routinely. I mean, I do it, but it's
Yeah.
not reflexive.
But it could
in
be.
our system.
It could be
Yeah.
something. Ross mentioned a drug called Teliso-V from AbbVie, and Ross just presented some great results at ASCO in June with that antibody-drug conjugate against MET highly expressed tumors. And so if that pans out, we could start needing MET expression with IHC. What I would say is not to worry, because the vendors are going to start including these. The academic centers are going to start including these tests. But we're learning. There's always new tests that need to be done and added to the assays.
So if a patient is in one of these centers in some 31 states, what are they going to get? And what does a patient need? If a patient doesn't see an IHC on their biopsy report, do they go get a second opinion? What do they do?
Look, there's nothing special about us. We just are fortunate that we spend a lot of time in a narrow area of cancer, lung cancer, and we're able to kind of hopefully keep up with the field. It is hard, I would say, for most oncologists to keep. I couldn't keep up in breast cancer, lymphoma. Could you guys treat those cancers?
Absolutely not.
Yeah.
They want you to hold it closer.
Yeah, and so I think this idea of second opinions and education is critical. I mean, I've had doctors call me, say, David, I got a patient with ALK lung cancer. Can you help me? And I'll say, well, send over the pathology, and they don't have ALK lung cancer. They have they're interpreting a test the wrong way. And it's not their fault. I think it's hard to keep up and understand kind of the complexities in testing. And I do worry about that because the field moves so quickly with these assays, like MET expression and HER2 expression, this conversation we're having now, I doubt it's really happening at the general oncologist level in the way we're talking about it. But that's not a slight against general oncologists. It's just there's a lot of information out there. And so it speaks to this importance of getting second opinions, seeking out folks who do this a little more often so that they at least can guide your colleagues on how to test. I don't know how you guys feel about that.
Yeah, I agree with that very much. I think your point about keeping up with all of these fields concurrently, which is the expectation of many community or general oncologists, it just seems like an impossible task. I mean, I lose sleep trying to keep up with lung cancer as the only disease that I see, and so I can only imagine someone trying to do that along with everything else. And so I do think there are critical junctures at the time of diagnosis, at the time of progression, where either getting a second opinion or checking back in with your prior second opinion doc is appropriate to make sure that the tests are being run, to make sure that there are not clinical trials that require additional tests to be run, right? For drugs that are not widely available yet, that the general oncology centers couldn't run even if they wanted to, because they're not standard of care. And so I echo your sentiments precisely that this is not meant to be disparaging towards community oncologists. They serve a tremendous value, but it's just impossible for them to cover 100% of the breadth of these diseases.
Ken, as we're having this discussion, I'm realizing that maybe it would be helpful to zoom out just a little bit and just to describe the pattern and the landscape of acquired resistance mutations upon progression. So, what we're talking about is when, your cancer progresses on a TKI, let's say alectinib or brigatinib. As you see here in the chart, that pie chart on the left, the gray area is the area that represents the cases where there is no mutation within the ALK kinase domain. And that occurs, depending on the series, generally about 50% of the time. So about half the time, when there's progression on a second generation TKI like alectinib or brigatinib, there is a mutation within the ALK kinase domain that can be addressed with a better ALK TKI, where, be it lorlatinib or a fourth generation TKI in clinical trial like Nuvalent. So that's what we're looking for when we're talking about the need to reprofile the molecular situation with a liquid biopsy or a tissue biopsy. But it's important to note that the other half, the other 50% of the time, we're not able to detect a specific ALK resistance mutation. And it doesn't mean that it's not there, to David's point about just the different technologies in detecting this. But so it doesn't mean that you shouldn't necessarily try lorlatinib or get on like the Nuvalent trial. It just means that maybe we should look additionally for other drivers like MET or HER2 and things like that.
Thank you, Vincent. So the care for ALK patients is a lot more complicated. I bet you're figuring that out, right? It's no more is it you get one TKI, when you progress, you just get another TKI. Now there's an in-depth evaluation that needs to be done to make sure that we know what your tumor looks like at the molecular level so we can give the best treatment. Nobody's got the same tumor in this room. We call them ALK, but they're all different. And I think what we're talking about here is we want to know what makes your tumor special, and so that we can target it. So thank you. We're going to move to the next presentation. Now we're going to talk about, when we've touched on this already, recurrence without an ALK resistance mutation, or it's not really sure, or you can't get a biopsy. All those things are all too common. So now we're talking about a little older individual who presented with difficulty breathing, cough, and fatigue. CT scan showed a lung mass, adenocarcinoma, negative for brain mets, positive for ALK rearrangement, got put on one of our really great TKIs and had a really great response and is back to work. Scenario we see quite often, fortunately. Several years later again, patient has worsening cough, dyspnea, and bone pain. Now the recurrence is systemic with multiple locations, lung, bone, lymph nodes, not in the brain in this case. There's no histologic transformation, and that's a really important aspect, and we should discuss that once I finish reading the case, because you can't figure that out without a biopsy. And there are people in our community who have had histologic transformation found in their biopsy and have responded really well to treatment appropriate for that transformation. Molecular testing looks exactly the same as the first one. And this comes back to what we were just talking about. What other biomarkers need to be done? Is it routine? How do you make sure you get MET, HER2, whatever the other biomarkers should be? So maybe we can, Carl, this histologic transformation, what is it? And
yeah, so I mentioned this briefly in one of the Q&A sessions yesterday because it came up. And so I apologize if this is redundant for a few of you, but typically ALK fusion lung cancer is a non-small cell lung cancer diagnosis, and almost exclusively adenocarcinoma. There's some nuance to that. Adenocarcinoma is the most common type of non-small cell lung cancer. It means you can see glands under the microscope. And this is often how it remains throughout, but there are rare cases where the tumor, as a resistance mechanism, rather than acquiring these more subtle mutations in the ALK kinase domain that allow it to evade the TKI that the patient is currently on. Instead, the tumor adopts an entirely different format. It will switch, as we say, to, for example, squamous cell carcinoma or most ominously small cell carcinoma, or at least neuroendocrine carcinoma. And in these cases, the data suggests that the tumor has, in doing this switch, has lost its addiction to the ALK fusion protein in many cases. So in other words, it's not that the drug isn't targeting what it's supposed to target anymore, it's just that the tumor doesn't care. That the tumor has different drivers now. You know, if you have small cell transformation, often you've lost these tumor suppressor genes that kind of keep the wheels on. And typically, these need to be treated rather than with a change in targeted therapy, instead with either an addition of or a complete switch to chemotherapy that's specifically designed for the histology that's now been adopted. And so this is really, I think, the biopsy is important for a number of reasons, but this is something you get back immediately from the biopsy. This does not take the 2 to 3 weeks of next generation sequencing testing. This is something you can act on immediately if you see that. And it's a little bit, I don't want to express it as an emergency, but it's a little bit more of an urgent situation too, because usually when we think of the single point mutations that may drive resistance, these tend to be slower growing, whereas the histologic transformation can actually expedite the growth of the tumor. So it's something you want to identify and intervene upon very quickly.
Yeah, so just to underscore one point there, if you have progression and it is significant progression from your prior scan, as opposed to sort of just gradual progression where one or a few or multiple spots are just a little bit bigger, if it's significant progression, I firmly believe, and I think David and Carl would probably agree, we definitely would prioritize a needle biopsy, because we just want to make sure we don't miss a potential histologic transformation. Again, not to suggest that this is very common. Histologic transformation is actually fairly uncommon in ALK. More common in EGFR, I think, as Christine mentioned yesterday. But it's just something you don't want to miss, because it really does require a complete shift in your treatment approach.
Yeah, not much to add. I think the good news there is chemotherapy, which tends to be what we do for a lot of the gray part of the pie chart there, for the most part covers that transformation, but there are differences in histology. Our choice of drugs will be different for, say, small cell or neuroendocrine cancer than it would be for, say, squamous histology.
So David, if you have a patient in this situation, what other tests do you order?
Yeah, we kind of addressed this with the first case. We did it yesterday. The first thing is just looking kind of head to toe, making sure now that cancer is kind of showing a new face. In this case, several years later, it's almost like a redo, like, let's look at the brain again. Let's make sure that the body's been looked at. In this case, other lesions were discovered in the bones. And so that might change kind of your choice in adding something to the care, for example, bisphosphonate or rank ligand drug like denosumab or Xgeva. But I think the testing and the approach here is pretty comprehensive. I mean, I can't think of any other tests I would send off that we haven't discussed, or any other strategies, but just I do think when you're talking about any cancer where someone has had it and then many years go by and something's changing, you want to kind of relook at things and almost start over in your workup and evaluation, and just not assume that everything should be the same. In this case, it looks like everything's the same. It's just that there's cancer in other places. But there's no reason this patient in this example couldn't still do well with a change in the TKI. And we've talked about this in multiple ways today, but if you got drug A and you switch to drug B, it could very well work for years in this setting like the first one did. But obviously we'd kind of start over, and we'd start probably if this patient in the first part of their care, their scans were less frequent, and you went from 2 to 3 to 6 months. I mean, I have a patient who's talked me into only coming in once a year. It makes me very nervous, but she wins. But if we found cancer again that had changed, I'd make her start coming in more often again. And, so we'd have to kind of change our approach.
I want to emphasize a point that David made that I think could seem counterintuitive at first, because we've emphasized both today and several of the talks yesterday that a lot of the newer generations of TKIs are designed to hit these on-target resistance mutations, right? The resistance mutations that occur in ALK. And this is a patient where we have not identified those. But I suspect in many scenarios, if we had a newer generation to try, we would all agree that you still give it a try, right? Because we do not understand the full breadth of the resistance mutations that these hit because of the heterogeneity that you mentioned before. The needle may have just gone into an area that did not have the clone that is driving the resistance in these cases. And so this would not exclude this patient. This might make you a little bit more open-minded to things like chemotherapy or certain other modalities. But I think your first instinct is probably still to give patients a shot with a new generation of TKI.
I'm curious, guys. You saw the slide yesterday Ross had. It had like red, green, yellow. They were called the IC50s, kind of the drug potencies, and they had the different columns. You guys remember that? And Ross was making a joke about an IC50 at 49.9 versus 50.1 is the real difference. And I would bet these guys were like me. When we first started getting those IC50s with these new drugs, we used to keep those at our workstation. And so we would, like, okay, I'm going to have that right next to me. And when I get back to mutation, I'm going to see what color is it, yellow, red, or green. I'm sure you guys probably did some bit of that. We still do it. We don't use the charts anymore. We just go online and look them up. But rarely is it helpful. Rarely is it helpful. And do we even know if it means anything? Like, what happens in a Petri dish, is that really what's going to happen in a patient? And so would I withhold a drug that looks pretty active against a lot of different mutations because we're not finding that mutation in the biopsy we just did? Probably not.
So should a clinical trial option always be part of the discussion in this setting?
Well, I mean, the easy answer is yes, because it's how we advance the field. And so, for those who've been on clinical trials in this room, you're helping generations of other folks, and it's even if the trial doesn't work. I mean, we hate that, right? But that's how we learn. We learn that this drug doesn't work in this way, so let's change it and see if it can work in this way. And so research is critical for everybody, for not only folks right now today looking to find the next best therapy for them today, and that's, I think, when we talk to patients about clinical research, we're always thinking about the patient right in front of us. And the patient will say, well, I want to help other people. And that's great. There's no question research helps generations of others behind that patient in the room. But we're doing it to help the patient in the room right there because we think it could be a better option for them.
Kirk, I think we've got 13 minutes. Can we take a few questions? Yeah, please. I can't, the lights are in our eyes. It's hard to see.
Yeah, I can repeat.
Questions. Good morning.
We got one
Wake
up
up,
here.
everybody.
There's one up here. I'll just repeat it.
Would you first increase the dosage back to?
Yeah, it may be, and I'm not going to be Oprah Winfrey here. Who's from Nashville, by the way. I was in the elevator at our hospital this week, and they were highlighting nurses who won awards, and there's a nurse whose last name is Winfrey, and it must be Oprah's like granddaughter or niece. So, Carl, the question was, if you started, say, a newly diagnosed ALK positive lung cancer on a lower dose, let's just say 75 of lorlatinib, and you saw a scan with more disease, would just increasing the dose make sense?
Yeah, I think that would be the first place that and in fact, I've done that in my practice from time to time. I've had a few patients where we've dose reduced alectinib, brigatinib, lorlatinib, and particularly if I see some mild changes in the CNS, but truly, I think if you saw modest growth anywhere, my first instinct would probably be just to increase it back to full dose and do a short interval scan from there.
And if you allow me, Vincent, yesterday with Angel and I on a virtual kind of session over there, someone asked about leptomeningeal disease, or sometimes this term we use called carcinomatous meningitis. And could you comment a little bit about the super high doses that have not really been approved, but we talk about using sometimes?
Yeah, so David's referring to leptomeningeal disease where the cancer has spread not just to the brain, but really in the cerebral spinal fluid that surrounds the brain and the lining of the brain sometimes. And so this is really distinctly different from just your usual brain metastases, and really represents an area of frankly, that we need to do much, much better at in terms of treatment, because across all solid tumors, leptomeningeal disease is really an area that we don't have very good treatments for. In ALK, fortunately, I think it occurs less often than, for instance, EGFR, but we definitely see it. In terms of increasing doses of the TKI to address leptomeningeal disease, unlike EGFR, there really isn't even a large retrospective series to support, for instance, alectinib 900 milligrams twice a day as a potential approach to treat leptomeningeal disease. Really, in these situations, we would just prioritize the most potent TKI that gets into the brain as possible. And that would be lorlatinib, that's FDA approved, or if the clinical trial allows, something like a fourth generation TKI. But I personally, in my own practice, I don't increase the doses of, for instance, alectinib or brigatinib, to try to address leptomeningeal disease, because I'm not sure that that's really that's really effective.
All right. Summer, we have another question? Here we go.
We have one over here. Ken, to
Yep.
your right. To your right.
Okay.
I'm over here. If you're following along in case 2, and let's say you do chemotherapy, you carboplatin, pemetrexed, not a great response, do you biopsy again? Tissue biopsy again after 6 doses?
Yeah, maybe I'll just take a stab at that. And we're probably all different this way, but in that example, I probably am continuing the TKI and adding chemotherapy in. And so to your question, and then there's progression, do we go back through the same process of rebiopsying, relooking? And the answer is yes.
Thank you.
I don't know if you remember, if you guys were in the session yesterday, but that I was in. There's a great paper out of Mass General that Alice Shaw published many years ago on a single patient talking about resistance. And the gist of the paper is that the patient started, say, treatment A, it stopped working, they got treatment B, they got treatment C and D, and then they reprofiled the tumor and it was sensitive to treatment A again. It was just amazing, and it speaks to diversity and clonal evolution and how you could selectively create clones that might be sensitive again. And I mean, it was a very, I know you guys saw that paper. I mean, it was an instructive paper in oncology about why biopsies can teach us more about what's actually happening in the tumor.
A question I had is, could you comment a bit on whole brain radiation? If you have numerous mets in the brain that can't be radiated, how do you evaluate that versus lorlatinib, going on to lorlatinib?
Yeah, I think that's, as our TKIs get better and better at treating brain metastases, I think knowing when to deploy radiation and how to deploy radiation is becoming more complex. Probably more complex in a good way, but more complex. My sense would be if I had a patient who was on, say, a second generation TKI and developed multifocal asymptomatic brain metastases that were beyond the scope of what someone might consider for stereotactic radiation to the brain, I would strongly consider giving a shot at a potentially more brain penetrant TKI before committing to whole brain radiation, because I think we've all seen patients that had CNS progression, say on alectinib or brigatinib, that have then had CNS response to lorlatinib. Whole brain radiation does not guarantee complications or toxicity. I have many patients that have undergone whole brain radiation and who lead a very, very normal life. But I think there is a sense to some degree that with radiation to the brain, you get one, maybe 1.5 shots on goal there, and you want to save those for when truly you've exhausted any other option.
Yeah, I completely agree. I mean, in the era of these highly active brain penetrant TKIs, you really have to approach radiation more judiciously, I think is really my personal opinion. We've seen cases where, even as discussed yesterday, I think, whole brain radiation or any radiation, but in particular whole brain radiation, is a risk factor for lorlatinib neurocognitive side effects. Radiating the brain really has to be considered very carefully in the context of other subsequent therapies that you may be put on.
Hi.
Next.
Yeah, I have a question about off-target, where you have an off-target driver that's happening. I know that FISH test will hopefully pick up on that driver. So we've had a discussion about dark matter as an example. What do you do with someone who's progressing, nothing shows up in the liquid biopsy or tissue biopsy? How would you approach that? Walk us through that, please.
Yeah, if I understood the question, what do you do if you do liquid testing and nothing really shows up? Hopefully I got that question correct. I think in some cases that's all you can do, right? Either the patient doesn't really want to have a biopsy, you don't have time to do it, or it cannot be safely done, and that's what you have. I mean, you got to work with the liquid, which didn't show you any new insights. In that example, it would depend again what the first therapy was, how they did on it, in terms of what I'm switching to. If they've already kind of exhausted the TKIs, I'm probably moving to chemotherapy with the TKI outside of a trial. But when you can get a new biopsy, like we were talking about, our goal is to just do comprehensive testing, ideally in a place that can do DNA and RNA. So FISH is not, at the moment, something we need to go back to. I'm sure that'll change. Actually, it probably is changing. I take back everything I just said. With MET, we're re-looking at FISH expression levels that NGS testing is not adequately giving us. And so IHC, FISH, and NGS are increasingly going to be part of kind of how we analyze what's happening in the tumor. It's just kind of funny, we're circling back to the way we used to do testing.
I'm just marveling at how much our patients now have to have a molecular biology degree in order to keep up with their...
Oh, yeah.
There will be a quiz at the end about FISH, IHC, NGS.
We have time for one more question.
I have a question regarding when you do the sequencing. Can you just touch briefly, if that's even possible, on, because my initial testing was DNA, but there's more talk about RNA sequencing. How is that different or better, or how should we request that?
Yeah, I'll comment because I brought this up, but I'll let these guys address it. When I have somebody that's just diagnosed and we found ALK, I'm kind of done. ALK trumps everything, and that's what I'm going to use to drive care. Even if there was, say, a coexisting mutation, we talked yesterday with some folks about P53, CDKN2A loss, and other mutations that occur. But ALK is what we're going to use. It's our targetable mutation. It's what we can act on. What I was referring to is when we're looking at resistance, we're looking for every resistance mechanism to explain why cancer has changed in its behavior, and does that open up opportunities on or off a study. And so what I was referring to was looking for rare fusions. So a really rare fusion you probably heard about is called NTRK. It's extremely rare. You have trouble picking it up in the blood. Even a lot of our DNA vendors don't routinely pick up all isoforms of NTRK, but RNA allows you to pick up more of those NTRK fusions. You've heard the expression needle in a haystack. This is a needle on a farm, in terms of the likelihood of that being there. But, when we're looking under every stone and just trying to look over every option, in an ideal world, you would have DNA and RNA to help uncover everything that's going on in the tumor. And I think that's going to change. Over time, you'll see these vendors offering, today it's now 650 genes. Next year it'll probably be 1,000 genes. and one day it'll be whole exome sequencing, which you can get these days now. We don't know what to do with all that information, but the drugs that we have that can target TRK and RET and RAF and HER2, we do have those now, and they're in studies. So would we consider those as options for a patient if we found one? That's what I was trying to get at. I don't know if you guys would add more to that or not.
Yeah, I agree. I think if this is at the time of initial diagnosis, we're just looking for any test that will rapidly show us something that we can target, right? And so if we find ALK fusion on a liquid biopsy, on a blood-based test at that point, my testing is over and I'm starting them on a drug. But at resistance, I think it's a very different scenario where we're hunting for some of those needles in the haystacks, but also acquiring information that may not be useful to us at that moment, but could change in the near future, right? That you can go back and say, hey, we didn't have a drug for this, but now we do at a future time point.
I'll give you one example. Sorry to keep hogging the microphone. Because it came up yesterday with an online question, something called CDKN2A loss and CDKN2B loss, something we've seen for years on reports, and we're like, okay, can't really do anything about it. We're learning that CDKN2A and CDKN2B is associated with something called MTAP loss, MTAP. There are drugs in development right now to target MTAP deficient tumors. And so one day we might say, well, you have CDKN2A loss, let's test for MTAP. Let's see if you're a candidate for a clinical trial. And so you can see how the field evolves and changes. And this information, as was just said by Carl, might be helpful down the road.
Thank you, Carl, Vincent, and David, for a really great session.